Okay, we'll move forward, and then perhaps Jennifer, if you could ask some of those questions, that would be great, and we'll get the answers for that. I thought it was interesting. We're having an alphabet session this morning. Chantel gave us the 3 A's of awareness, acceptability, and accessibility. Stephen just gave us the 4 M's of what matters, what medications, mentation, and mobility exist. And so I thought I would add the 4 C's, which is what we need to give to people and providers, which is clear communication of any content, whether that's verbal or written or whatever, in context, because that's how they will understand and be able to be receptive to the ideas and the information that you're asking them to provide. In addition, we've talked about the product life cycle. I'm going to see if I can, now I can get to the question and answer. So before we go through the panel discussion, Mary Murray had asked, Jonathan, I believe this was directed toward you, how can you do outreach with electronic health records? Do people opt in to receive these kind of messages? Is the communication through their providers? They're trying to understand how this works with patient privacy. Jonathan, are you there?
Sorry,
okay.
I was mute. Thank you for those questions. Let me try to combine the 2 questions. I was listening to the great presentations and not paying attention to the chat until about a moment ago. So we use a combination of strategies. And so the electronic health records can be used to identify eligible patients based on inclusion and exclusion criteria. We are able conceivably to reach out to those through patient portals, although in low-income and minority and presumably older communities, patient portals may not have the uptake that they do have in more health literate and affluent communities, so they may not be the best strategy, though we have used those. But to go back to how do we build these relationships, and we heard this from several of the presentations, this is really about building trust. And so there's a transitivity issue here. So the patients trust their clinicians and the practices where they receive their care. And the practices have built and established a trust with the practice-based research networks that are committed to developing their ability to participate and lead research in their settings that are relevant to the patient populations they serve. So it's really the combination of the trust between the practices and the PBRN and the trust between the patients and the practices that allows for a warm handoff, and that's the introduction that the practices make to the research staff from the PBRN. And it's really that trust by proxy that I think is the most powerful ingredient in doing this kind of research. So whether we use the EHRs only to identify and then use trust by proxy and warm handoff strategies, or we use the EHR directly for outreach, they both leverage the health data and leverage the personal relationships.
Okay, thank you. We also had a question about how do we know the quality of data that the teleresearch has had, and a few different people talked about telehealth, so we can open that up. And in addition to that, someone wanted to know what eHealth and mHealth are, those terms.
Okay, so much longer discussion, but in brief, mHealth is mobile health, eHealth, electronic health, telehealth, using some combination of distance communications. It could be the telephone, could be the internet, could be a smartphone. So all of those together are ways of expanding access and enhancing communication. That's I think the first question. The second question, in terms of data quality, that's an ongoing challenge. And so I think that it's important that studies validate that people who are using these communication strategies understand the responses. And so we've built in some tests of reliability. It really varies by population and by measure. but it's not any different from asking the question, how do we know that the quality of measures are good? We know from studies that the quality of data that are collected by researchers using rigorous research definitions are going to be stronger. On the other hand, the quality of clinical practice information is going to provide much more real-world evidence. And so I think we do need to use internal ways of validating by looking at biologically plausible measures and consistency within and between measures over time, and then look at external measures. Do the measures that are coming out of electronic health records align with the measures that would be captured in national surveys or clinical trials that are designed with more rigorous data collection?
Okay, great. Okay, and then for Chantel, there was a question asking about the Barbershop study, that it's an excellent innovation, but how many Black men older than 85 still visit the Barbershop weekly? This is an important group we fail to reach. Chantel?
Yeah, so we obviously excluded men greater than 79, and to be perfectly frank, I'm not sure for good reason. But I think what was surprising from being in the barbershop is that, many of the men who actually go to the barbershop, frequent the barbershop, are not actually there to get a haircut. So when I say this is a social environment, a place for, exchange, people really go there to play dominoes, to play cards, to watch TV. And I mean, I'm kind of just thinking back to one particular barbershop that I worked in Compton, California. That was owned by a gentleman who was over the age of 70. All of his barbers were over the age of 60. Most of their clientele were older. And every time I walked in, there were at least 6 of them around the table playing dominoes. So I would venture to guess that there are more than you think. And, not everybody in the shop is there for a haircut. It really is a place for socializing, particularly for older adults.
Okay, thank you. And then this next question, I think, is probably open primarily for Laurel and Susan and Stephen. And that question is there any utility for having a quote, "Are you interested in being involved in research," unquote, or quote, "Have you any experience with clinical research," unquote, in your intake questionnaire or in a discussion with someone? So, Stephen, do you want to start us off there?
Yeah, I'm not sure what the questioner meant by the intake questionnaire, but I would certainly say that building a culture in a group of practices where we say research is part of what we do, it's part of making things better for our patients, and building that in does make sense. So if someone is connected with a large system, that would be really helpful. And I think it's also a means to begin to build a registry. And I think there was a question earlier about how you access patients through the EMR. And we try to get permission ahead of time. May we, contact you if their study is appropriate for patients like you, so that's already built in. So I would strongly recommend it. And some people will say no, but if you can begin that as part of the ongoing conversation, it's easier to recruit.
Okay. Laurel, any thoughts on that one?
Yes. Can you hear me?
Yes.
Okay, great. I think way before you get to the questionnaire portion, we need education within the community. When you get to the questionnaire, then perhaps there's not that pushback from the patient in that they already have some information about clinical trials. They may not have experienced that. They may not have been in a clinical trial, but they're aware of it. So that's where I see a peer group or a peer person speaking with others who are there. They're not trying to accrue them to a trial. They're just trying to inform them. And I think if we can do that on a better scale within our communities, within my community of retired people. I think that would be amazing to have those materials that we could present on an ongoing basis with no questionnaires at that point. Then we could proceed to the questionnaire.
Okay. Susan, any thoughts?
Yeah, I think it's important to, in this post-COVID and post-COVID age, to think outside of just our local areas as well, especially as we're having the opportunity for virtual and hybrid trials, to look at opportunities to reach a greater number of patients with more diversity and different experiences, backgrounds, even different parts of the country. We don't have to look just at the kind of traditional way of seeing just a physician or the group of physicians in the trial utilizing and reaching out to just their patient group. I think we can begin to think of going beyond that.
Okay. I know one of the things in a recruitment plan that I was involved with long ago, about 15 years ago, we had 3 different groups, right? We had what are the patient issues for that patient population. We had what are the issues for the sites and what their situation was in and what kind of material and things were needed there. And then also the referral base was our third prong, because most people don't think about that. But I think as we're talking about here with primary care physicians and other of the many subspecialties that a patient gets to, I work a lot in different cancers. And, you know, the thing I try to remind oncologists about is that's the last place the patient ends up, not the first. So if we think about the path that a patient has to walk through to get the diagnosis in the first place, what can be done about that? Mm-hmm. So I also have.
Oh, sorry.
Okay, go ahead.
Could I make one more point? I really wanted to make sure I got to this point, is also considering third arms with studies to look at patients who might not meet the eligibility criteria. I myself personally don't meet a lot of criteria because of my pre-existing conditions. So when I had HER2 positive breast cancer and had Herceptin and knew that Herceptin could cause heart failure, I knew that none of the information that my doctor could tell me about Herceptin would work for me. I mean, you know, nobody studied radiated chests and what Herceptin does to it. And so I think having those third arms where patients who fall outside of the norm are still are part of it. It gives us valid information that benefits patients, that patients want to know. And I just think that's so important to consider. So thank you for letting me make that point.
Sure. Jonathan or Chantel, do you have anything to add?
So this is where real world evidence, I think, is so critical. And back to the question about how to use the electronic health records. So that provides potentially the opportunity for that third arm or for eligible non-randomized participants to be included. I think we're learning about changes in assumptions about consent and under what conditions researchers can examine the data from patients without obtaining their informed consent in a de-identified or in a limited fashion. I think these are important issues that balance both patient privacy, but the opportunity to learn from the experience of a broader, more heterogeneous population. So I think it's really critical that we use all of that information, not just the patients who consent, which in and of themselves may be more selective than the patients who are seen in routine care.
Okay. Chantel, anything to add? Okay. Then I'm going to go on. We have someone from the planning committee and another speaker who's playing devil's advocate that I think is important to bring up. And that's talking about the primary care provider as an advocate for research, and that there may be some concerns also, because always there's the pro and the con side, right, of doing everything. So one question is, does this put the physician in the place of durable power of attorney for research participation? So that's one question. Another one is, do older or any patients then interpret the research as a part of clinical care? And the third one is, do they want to please their physicians? So it's an implicit kind of coercion. So Stephen, we'll let you start off with that and then have things.
Those are all outstanding questions. And I think I'd like to begin with the third, the implicit form of coercion, because I think that's a critical ethical issue. I think for the most part, primary care physicians, first off, are juggling so much in a 15-minute, 20-minute, if it's luxurious, sometimes 10-minute encounter, that asking to sell the study is very different than in a cancer center where the oncologist is directly involved in the study. So I think it's in some ways a broader cultural issue of why we want people involved in studies and not to be explicitly or implicitly negative about research. So I think that's super important, so that my message is always not to push people into studies, but are you interested? This might be of interest to you. I'm involved, but what's important is that you ask a lot of questions to the research assistant or the person who's on point for this. Even in my own studies, and I never do my own studies in my own clinic for obvious reasons, the importance is to be facilitative, but not to enroll directly. I do always say that, all studies should begin with a place of equipoise, meaning if we knew the answer to this question, we shouldn't be doing the trial in the first place. So I'm always clear with patients, they say, well, do you think I should do this like in a cancer trial and something else? I'm always very clear that we don't know whether this is going to be helpful or not. There's reasons to think that intervention X might be helpful. In a particular study, we don't know if you'll get that at a placebo. You're helping answer a question. And in that sense, I think this gets into the what's in it for me question. What's in it for you, older adult, may not be your direct benefit. It may be, but it may be for people like you. It may be your brothers and sisters. It may be the people you go to church or mosque or synagogue with. It might be, your next door neighbor. But unless we do this, we don't get the answers. And the benefits that you're getting of treatment today are because somebody else was in a clinical trial a few years back. So I always, I lean in as a primary care physician and an investigator into equipoise.
Okay, thank you. Anyone else on the panel want to comment on those questions?
Great set of questions. I agree with Steve that equipoise is the place to begin. Many studies, though, to think about this through the lens of comparative effectiveness research and patient-centered outcomes research. So while some research is still testing the effectiveness, the efficacy of a drug as compared to placebo, many studies are now examining the comparative effectiveness of two or more known to be effective treatments. And I think that's where this really becomes important, where we can truly say we don't know which one is more effective for you and for people like you. But I think what patient-centered outcomes research has added to this is the dimension, as several of the speakers earlier have said, of what's important to the patient. So while the clinical effectiveness may be similar between two or more treatments, there may be important differences that help patients decide from one treatment versus another. So I think that's where I would turn the question around and say it's really important that we engage people in research in their usual sources of care, as long as we have the protections, the oversight of institutional review boards, data and safety monitoring boards, the disclosure of financial incentives for the investigators, and the advocacy of freedom of choice, the autonomy that patients can make their own decision and feel comfortable. And finally, I think shared decision making is a really critical aspect here, where that conversation between a clinician and a patient can try to understand what the benefits and the risks of participating in a given study might be and why they might want to opt in or opt out of that study.
Okay. Anyone else? Okay. I would just like to reiterate that I think there's a difference between advocating for a specific study and trying to, as you said, Stephen, quote, sell it, versus what research is about, what the benefits of research are about, and why we do it, and what role people can play in that. So, and Laurel, I don't know if you have anything to add, but I would think that that would also apply to community champions. And in Chantel's example of the barbershop as well, they're there to promote overall health and what research can do, right? But not, hey, get on this study because we think this is important.
That's true. That's right? Very true. I totally support that, because I think first information is necessary. It's key for older adults, especially since they've been passed by all these years, many, many years. And now suddenly we're very interested in including them in clinical trials. And so my consideration is that if we can meet them, within their community, on their ground, not in the clinic, and well before there's ever an invitation to join the trial, they will be educated, they will be better able to come to some decisions. And as a caregiver, I think it's important that we also include that caregiver in those discussions. And caregivers oftentimes are right there along with that patient, as during any type of situation. Oftentimes they don't even drive. And if they're at that point, then the caregiver is key to moving that needle forward. Thank you.
Okay. Well, I think we'll move on. We've got about 5 minutes left. And I think an important question maybe to end with, and if everybody can kind of think about this and make a statement, instead of putting my slide up, it's much better to see you guys. So I'm just going to say what's on the slide, which is how do we start connecting the dots? We've heard a lot yesterday and already this morning, and we'll hear more today about really good programs, really good thoughts, ideas, different groups that are doing different things. And so one of the questions is, how do we start connecting the dots better and taking action on doing that to increase older adult participation in research for the short term? I mean, real steps that we could take forward. So an example of that is, we know there's some changes with COVID-19 that are happening in clinical trials that seem to actually be better for patients as well. So how do we make those changes permanent? And that will involve things from a structural basis, right? Reimbursement, design, communication, empowerment. There are other things as accessibility. So any thoughts that you have on that question? Anybody want to start that off?
That's a large question. As a caregiver and as, with all of the hats that I wear, I think it's really important that we continue with EVisits and that we be able to help other patients or become a person who can assist a patient if they can't participate in an eVisit. I think these are the important parts of COVID that we've learned. And if we can go forward with using those, and that doesn't expose that patient and the caregiver, not to even speak about the amount of time and the mileage and all of those things that are involved, I think that's a real step forward. Even though we're in the middle of a pandemic, there are lessons that we can learn.
Okay, thanks. Okay, if I have to call on people, I will.
Well, I'll pick up on Laurel's point. I think in some ways the telehealth has lowered the burden of entry, right? It doesn't require finding somebody to drive you to the clinic or the research center. It so much more than we, said was possible can be done from home. And that's important, although we have to continuously be aware of the electronic divide as well, the haves and the have-nots here, and be very conscious as we recruit and enroll. Who am I missing? What zip codes or community areas are being missed? How does this reflect the population I'm trying to get to? So, but that said, I think eHealth has helped lower some of the burdens of entry, and that's important. The other piece, though, is, I think Jonathan referred to it earlier, is looking at the outcomes that matter to people we want to recruit, and keep asking, what are the things that would be significant to this population, and asking individuals what matters. Our studies often depend on intermediate outcomes, a blood pressure, an A1C. And when you talk about what matters is, can I stay in my home? What matters is, can I not have a hip fracture? Or, can I play with my grandkids without getting short of breath? So understanding patient-centered outcomes is critical. And I think that's the great work that PCORI has driven for us, but there's a long way to go.
Okay. Any last thoughts from anyone? We're about to wrap up.
Because
Jonathan?
we don't have a unified health system. And so I think the challenge is, how can we create those virtual linkages, and understanding that each point of contact is unique and captures important information, but is only part of the picture. So the model of the network of networks that we try to build tries to broaden the view and tries to broaden the horizon of how information can be captured, can be aligned, and can be integrated. But we should be thinking about that not only for research purposes, that's the purpose of today's forum, but understanding how that broader view and integrated view of people's experiences across different health settings and non-health settings. I provided a single example, but we could look at many other examples of social services. If we want to truly intervene in the social determinants of health, many of these fall outside of the purview of healthcare practices. But nevertheless, if those are the primary issues, criminal justice, education, housing, food insecurity, homelessness, those are the things that are the primary concerns of individuals, they really need to be captured not only as risk factors, but as intervention targets. And so how do we broaden the domains of health in such a way that isn't mission creep for the health serving organizations, but at the same time recognizes they're part of a larger system in communities of social service and health service providers that need to integrate information, need to exchange bidirectionally what's happening to the people that they jointly serve, and so that those viewpoints and those data points can be incorporated not only for research, but also for care.
Okay. And one last question, and I realize we're running over just a little bit. There is a break after this for everyone who's attending. So our next session will start at the top of the hour, whatever hour that is for you. I'm in California, so it'll be 9 o'clock. The question is, what about maybe a reimbursement code for e-setup for patients? Is that something that is being discussed, being done? Where do we stand on that? Jonathan?
I love the idea, haven't heard of it.
Yeah, I haven't heard of it either, but federally qualified health centers are fortunate in that they are funded through HRSA for enabling services. And so I would put that setup as part of it. But I think from the Pew data that I quickly shared, it's clear that the setup is just one piece of it. And as was mentioned, for many people, my own in-laws and family included, telehealth visits require somebody who knows how to use that smartphone to go to their home to help them access it. So I think it's really two sides to it. It's enabling at the beginning and then providing ongoing access through a caregiver, a family or paid caregiver.
All right. Well, thanks. Oh, Laurel, did you have one more point? Oops, Laurel's frozen.
I clicked it and then I unclicked it. I just wanted to emphasize that some trials may include some type of a device that the patient can use, but first we have to educate them on using them. And that's where there's this grassroots effort where we can help other patients. If my neighbor doesn't have access to an eVisit or isn't tech savvy, I can help them. And, I'm a patient advocate. So those are the things I do. And I'm happy to help.
Okay. Thank you very much. Well, thank you, everyone. I thought this was a great session. Of course, I'm a little biased, but we set it up well, and you guys were great. Your presentations were wonderful. So, and thank you for the audience for being so involved as well. We appreciated your questions and thoughts. If we haven't answered anything, just set us up in the chat privately, and we'll try to do that. And everyone can take a break now until the top of the hour. So we've got at least 10 minutes. Thank you very much.